So we're going to start with the second half of our reproductive system, picking up where we left off, which was with the female reproductive system. So in a secondary follicle, the theca differentiates into the theca interna and theca externa. The innermost layer of granulosa cells become the corona radiata. Remember and recall that the corona radiata is what is protecting that egg from the environment of the vagina, as well as forming a barrier for one sperm to enter instead of multiple. The secondary follicle becomes a mature Graafian follicle as it increases size and pushes its way to the surface. While in the mature follicle, the diploid primary oocyte completes meiosis 1, producing a haploid secondary oocyte with the majority of the cytoplasm and a haploid first polar body. Now, we have talked about this in the previous slides where that first polar body may or may not go on to divide, but eventually it gets digested and broken down. The best oocyte persists. At ovulation, both cells and the corona radiata enter the uterine tube. If sperm are present and fertilization takes place, the secondary oocyte continues into meiosis 2. So that's an important step, that we realize that meiosis 2 is not completed until fertilization occurs. An ovum and a second polar body form. As you recall, that second polar body will be degenerated and phagocytized. The ovum becomes a zygote when it unites with the sperm. We can put it to chart to see exactly what is going on here. So we see our diploid oogonium up here. We undergo mitosis to get our still diploid primary oocyte. Meiosis 1 gives us our secondary oocyte. We are now haploid or 1N. That first polar body may or may not, either way, it will get broken down. That secondary oocyte will be introduced to a sperm cell, at which point fertilization will occur. We then undergo meiosis 2. That second polar body will also be kicked out and destroyed, whereas we have that newly formed zygote. Now, the nuclei of the sperm cell and the ovum unite. This is forming a new diploid cell, so don't get confused with the 2N here to the 2N up top. They are completely different. This is a new genetically distinct individual. Now we can overlap two processes. We look at table 28.1. We look at age compared to oogenesis compared to follicular development. So we start in the fetal period. We notice that the oogonium is turning into the primary oocyte and meiosis 1 is paused here, so we pause it in prophase 1. We now have this primordial follicle nest. These are those roughly 300,000 eggs that you're born with. Childhood, no development of the follicles, nothing's really changing until you hit puberty. At puberty, we have a primary oocyte still in prophase 1 is now going to enter into that cycle we just talked about through meiosis 1 and meiosis 2 to eventually, if it fertilizes here. Remember, here is our polar bodies that get degenerated and destroyed. But now look at the follicle overlapping this process. From the primordial follicle to the primary follicle to the secondary to that tertiary Graafian follicle to the expulsion of that egg at ovulation. Now that we have covered the actual ovulation of that ovum, we now have to talk about where it goes. So females have two uterine tubes that extend from the uterus to the ovary. Realize that they are not connected, not attached. The ovaries are freestanding, connected by connective tissue holding them in place, the ovarian ligament, the broad ligament, the mesovarium, etc. And then we have at the end of these fallopian tubes, fimbriae. And those fimbriae kind of just dangle down there and eventually during ovulation will creep their way up, sweeping that egg into the fallopian tube. The tubes are the pathway for sperm to reach the ovum and for the secondary oocytes to fertilized ova to travel to the uterus. The end of the tube is the infundibulum. The projections are called fimbriae. The ampulla is the widest portion of the tube. Now, we go to the middle portion of this tube, which is where fertilization will occur. So let's get a look at this reproductive system, this internal structure. Let's start, and we're going to introduce more stuff that we will be coming up in the upcoming slides, but I just want to point to everything while we have this all-encompassing picture. So a couple things. we look at our ovaries. Remember, we have two of them. They're about the size and shape of an almond. We look at the connection. Again, notice that the fimbriae, the uterine tube, is not connected to the ovary. It's kind of just free floating. Those fimbriae are kind of brushing up along the edge. We have our ligaments, ovarian ligament, broad ligament, uterosacral ligament, all these ligaments that are sustaining and holding this structure in place. And again, our suspensory ligament up here. Now, look at our tube. We have our uterine tube, we have our infundibulum, so that beginning. We go all the way to the uterus. Now, our uterus is about the size and shape of a pear. It is very muscular. The broad portion on top is known as the fundus. When we work our way down to the bottom of the pear, we have a couple spaces to look at. The opening, the initial opening of the cervix is known as the external os. As we move our way to the interior, we have an internal opening called the internal os. And then the canal that works its way through is the cervical canal. Now, as the uterus pushes into the vaginal canal, so here's our vaginal canal, a couple things to realize, which is going to be that this vagina has folds. Like in the stomach, those folds are called rugae. In the vaginal canal, they are the same. The second thing are going to be these horns that are formed in the front and behind, and they are anterior and posterior fornix. So the fornix is that space that's formed due to the cervix pushing into that vaginal canal. Now, a couple more things to look at. Look at the uterus. The main portion is known as the body. Let's cut through this and look at the layers, the important layers here. So we start with the innermost layer. That innermost layer is known as the endometrium. Now, this layer is important because it is responsible for the engorgement of blood and nutrients that will implant that fertilized ovum, that zygote here, and sustain it until the development of the placenta. Also during menses, this is the layer that sloughs off, and we'll look at that 28-day cycle and see what's exactly going on there. The thickest layer is the myometrium. Now, the myometrium is smooth muscle. It will contract. Those uterine contractions you get to help push the baby out is in part due here. The outermost layer is the perimetrium, and the perimetrium is what's going to surround and protect the entire uterus. It is continuous with those ligaments that we outlined a little bit earlier. So we're going to continue with the uterine tube and look at its histology. The uterine tube has three layers: a mucosa, a muscularis, and a serosa, and that's because it is continuous with the peritoneum. The simple ciliated columnar epithelium of the mucosa contains cilia. Its job is to help move that fertilized ovum or secondary oocyte towards the uterus. So it has this sweeping action. We're also going to see PEG cells. PEG cells in the tube are going to be secreted to provide this nourishing fluid for that ovum. We can look at the histology. So put to picture everything we just talked about. We can see that stereocilia, that cilia on this columnar epithelium. We see some PEG cells lying in between. They are non-ciliated, so that's important. Remember, they're secreting this nourishing fluid. So again, we can look at a scanning electron micrograph of this. Here's that PEG cell. Here's all the yellow is all the stereocilia, all the cilia that's helped sweeping and moving that egg into and through the fallopian tube. The uterus is part of the pathway for sperm deposited in the vagina to reach the uterine tubes. The top of the uterus, as we said before, is the fundus. The central portion is the body. The inferior-most portion that extends into the vaginal canal is the cervix. The isthmus is between the body and the cervix. And ultimately, the uterus is where a fertilized ovum will implant. As we look at some of the internal anatomy of the uterus, the interior of the body is the uterine cavity. The interior of the cervix is the cervical canal. The opening of the canal into the uterus is the internal os, and the opening of the canal into the vagina is the external os. To look at the picture, look at the previous slide as I outlined and drew and identified these specific regions. Histologically, there are 3 layers to the uterus. The perimetrium, or the serosa. It is the outermost layer. The myometrium is the middle layer, consisting of 3 layers of smooth muscle, and the endometrium is the inner layer. The inner layer is made up of 2 layers, 2 stratums. One is the stratum functionalis. This is what's shed each month during menstruation. And the stratum basalis. Now, staying consistent with our terminology, our basal layer. This layer is permanent and is what gives rise to new stratum functionalis after each menstrual cycle. Let's look at the histology of the uterus. So a couple things I want you to look at. The slide on the left has 2 sections of uterus at different stages during endometrial growth. So the one here, we'll label this 1, we'll label this 2. Okay. The first one, look at the stratum functionalis, right? That endometrium. It is relatively small. Here's our stratum basal right here. That's what's going to give rise to that functionalis ahead. That large myometrium. Now, these endometrial glands here, you see them all, are what's going to fill and engorge with blood and nutrients. And you see them enlarging into, look how many there are, look how much larger they are. So this is a proliferative phase. So what's basically happening is the endometrium is growing. This stratum functionalis is swelling with blood and nutrients. Look at the size here compared to the size here. It is almost 3 times as thick. Now, the myometrium is not changing, but you're seeing less of it because of the growth in the endometrial lining. Now, details of the endometrium, we see that we have our lumen, the space up above, ciliated, simple columnar epithelium, our stratum functionalis, all of our endometrial glands, and our stratum basal or basalis. Let's take a quick look at the blood supply to the uterus. Now, the uterus is highly vascularized, which is why it engorges with all this blood and nutrients and nourishes a zygote. The branches of the internal iliac artery, called the uterine arterioles, supply blood to the uterus. The uterine arteries give rise to arcuate arteries that feed the myometrium. These branch into radial arteries that go deep into the myometrium. And then ultimately we have straight arterioles that supply the stratum basalis. In this slide, we can see how highly vascularized the uterus is, putting to picture some of the arteries and arterioles that we saw. So again, let's look at our radial artery, our arcuate artery, our uterine artery, leading, so that straight arteriole. From the radial artery, we get the straight arteriole that's leading to our spiral arterioles. That's why they're spiraling their way through. And ultimately feeding this endometrium and myometrium with nutrients and blood. Let's work our way to the cervix. We have these specialized cells on the cervix. They're called secretory cells. They produce cervical mucus, which is chemically more hospitable to sperm during ovulation. It's less viscous and more alkaline. Remember, we're seeing this mutualism where the vagina is changing its own environment to be more favorable to sperm. Now, talk about how we have evolved together. That secretion also helps to nourish sperm and may also aid in capacitation. So this is the final development and maturation of the head of that sperm. So again, pretty interesting that the vagina is secreting stuff, mucus, cervical mucus, which is going to help maintain the health of sperm by nourishing it, as well as allowing it to fully mature. The next part of this of the female reproductive system that we have to look at is the vagina. It is a fibromuscular canal. It's lined with mucus that extends from the body's exterior all the way to the cervix. If we look at the histology of the vagina, the mucosa of the vagina is continuous with that of the uterus. We notice that it is stratified, non-keratinized epithelium, stratified squamous, non-keratinized epithelium. Right? So we have the lumen, the space in the vagina, and we're looking at the mucosa. We see that we have our lamina propria right below it, And then if we move to our picture on the left, we see our muscularis. So we have a outer longitudinal layer and inner circular layer. Now, interesting note, we are outside of the peritoneum. So we no longer have the serosa. We are now, again, with the adventitia. Let's continue to look at this epithelium. Now, the epithelium and areolar connective tissue of the vagina lie in a series of transverse folds. These are called rugae. I pointed this out to you in a picture in the previous slide. The muscularis is composed of an outer circular layer and an inner longitudinal layer of smooth muscle. These together allow the vagina to stretch, especially during intercourse and childbirth. There is another layer covering the vaginal orifice that we have to talk about. It is called the hymen. It's a thin fold of vascularized mucous membrane that partially closes the inferior end of the vagina. So the next question is, does everybody have a hymen or a fully intact hymen? And the answer is no. Everybody's hymen is a little bit different. Some are fully intact, some are partial, some are missing. The reason for this structure is really unknown. Scientists really haven't nailed down a purpose for this vascularized membrane. Now that we've finished the majority of our external anatomy or internal anatomy, let's look at some external anatomy. We have pointed this out at one of our previous slides in our first part of this reproductive system lecture. So let's look at the vulva. This is going to refer to all external genitalia. For the female, the vulva is going to include the mons pubis, the labia minora, the labia majora, the clitoris, and the vestibule. The vestibule includes the hymen, the vaginal orifice, the external urethral orifice, and openings of ducts of several glands. So in this inferior view, we get to see the vulva and all the associated structures. So we see our two labias, minor, major. They're spread so we can see the external urethral orifice, the prepuce of the clitoris, the vaginal orifice, the hymen, the anus, and lastly, that fatty upper vaginal pouch, the mons pubis. Let's look at some of the glands for the female reproductive system. The first gland, known as the periurethral gland, also called Skene's gland, is the homologous structure to the prostate. So when we say, do females have prostate, most people say no, when in actuality they do. It's just not called the prostate. It is a periurethral gland. Its job is to secrete mucus, and it's embedded in the wall of the urethra. Next are Bartholin's glands. These are greater vestibular glands. They produce mucus during sexual arousal. What this does is really provides lubrication. They are homologous to the male's bulbourethral gland. The next is the bulb of the vestibule. There's two masses of erectile tissue that engorge during sexual arousal. What this does is it narrows the vaginal orifice, applying pressure to the penis during intercourse. It is homologous to the erectile tissue of the penis. So as you can see, all the structures in the male reproductive anatomy are homologous or similar to our structures in the female anatomy and serve similar purposes. The next thing we're going to look at is hormonal regulation of the female reproductive system. So let's look at our two distinct phases. So we're talking about the ovarian cycle. We deal with what happens in the follicular phase and the luteal phase. So as these names allude, the follicular phase is what's going on in the follicle. The luteal phase is what happens after ovulation. So we see that gonadotropic releasing hormone, we see pulses. So we see a huge surge or pulse right here at around day 14. So what's happening right before day 14? So gonadotropic releasing hormone causes FSH and LH secretions to surge, and this is going to surge until luteinizing hormone causes a corpus luteum to secrete progesterone. We'll talk about what progesterone does in a little bit. Now, what happens closer to day 14 into that ovulation cycle? So we have that secretion of LH and FSH. So we're secreting those two hormones. We know that FSH stimulates the follicle. It is going to be blocked by another hormone called inhibin that's going to be released from that follicle. Luteinizing hormone peaks due to estrogen from the follicle, and this is going to help pop that egg out. So you see right here, from luteinizing hormone, we actually get ovulation. And then we form that corpus luteum. So that follicle will continue into an endocrine structure. Now, once we have this mature corpus luteum, we see that it starts pumping progesterone and estrogen, progesterone being the predominant hormone here. If fertilization does not occur, that corpus luteum will degenerate into scar tissue known as the corpus albicans. So, what is our window of fertilization? And the answer is pretty straightforward. So, the question is, when can you get pregnant, or how many days can you get pregnant? And the answer is about 12 to 24 hours. That's it. And where does that 12 to 24 hour window occur? Right here, from day 14 and 15. Before day 14, there is no expulsed egg, so nothing can be fertilized. After day 15, if ovulation or fertilization does not occur, the egg physically disintegrates and degenerates. So after day 15, there is no egg to fertilize either. So our window is roughly 12 to 24 hours. Now that we looked at the ovarian cycle, let's look at our uterine cycle. We have 3 phases. One menses from about day 0 to 5. We have a proliferative phase. We introduced this when we talked about the uterus engorging with nutrients and blood and those endometrial glands growing. And then our secretory phase. This is the phase that we are going to wait for signals from the body saying that ovum has been fertilized or not, and will respond to progesterone and estrogen, specifically progesterone, to say whether we will keep this endometrium engorged with blood, waiting for the implantation of a fertilized egg or zygote, or we will return back to menses, back to day 0. Now, one other thing to notice, look at basal body temperature. At day 14 at ovulation, it does increase, not much, but it goes up 0.3 degrees Celsius. So what's happening? Estrogen comes from the follicle first due to the release of follicle-stimulating hormone. This stimulates proliferative phase of the uterine cycle, and then we get inhibin from that follicle is going to block FSH, which gives us a decrease in estrogen, until luteinizing hormone is able to stimulate the corpus luteum to secrete estrogen and progesterone on its own. We stimulate the secretory phase. As a result, a drop in estrogen and progesterone due to the corpus luteum degeneration, which is basically saying no pregnancy, no fertilization, and the corpus luteum will degenerate. We enter menses, and gonadotrophic releasing hormone begins to increase. There's no more progesterone blocking it, and we restart the cycle. Now we can put it all together, looking at our urogenital triangle and what's occurring and where everything is in relation to muscles, structures, etc. So at top, we have our pubic symphysis holding our pubic bones together. The bulb of the vestibule, remember this is contracting down on the vagina. Our ischiocavernosus muscle, our Bartholin's gland here, right? So similar to our bulbourethral gland in the male, our superficial transverse perineal muscle, our anal triangle, external anal sphincter, our coccyx, our gluteus maximus muscle, our anus, our ischial tuberosity, and our urogenital triangle, our bulbospongiosus muscle, vaginal orifice, which is open, and our external urethral orifice with the clitoris above it. Our next few slides are going to summate what we just talked about in our previous charts. So let's review our ovarian cycle. We have one follicular development, a few follicles mature at puberty, and the oocytes within grow. Follicles are going to secrete estrogen, and one follicle grows more rapidly than the others, becoming the monthly Graafian follicle, and oocyte that's going to go through meiosis 1 to produce the secondary oocyte, while the others are going to deteriorate. This takes about 1 to 13 days. At day 14, we have ovulation. The Graafian follicle will rupture, releasing the secondary oocyte surrounded by the corona radiata. Day 14 to 24 is our luteal phase. The ruptured follicle will be converted into the corpus luteum, which is going to secrete estrogen and primarily progesterone. And then days 24 to 28, the luteal degeneration, that corpus luteum degenerates and stops secreting progesterone and estrogen and turns into the corpus albicans, which will persist as scar tissue. Which leads us to a review of the uterine cycle. So days 1 through 5 is menstruation. So portions of that endometrium slough off. This includes blood vessels, resulting in blood loss. The next phase is the proliferative phase. This occurs from day 6 to 13, where the endometrium is repaired and undergoes growth. We then have the secretory phase, days 14 to 24. The endometrium increases in size, glands reach maximum secretory activity, and vascularization is at its maximum. Then we have our premenstrual phase, days 24 to 28. If we get no fertilization and no implantation, glandular secretions cease, blood vessels involute, and endometrium begins to disintegrate and prepare to slough off. Now let's look at some key hormones for the female reproductive system. First, gonadotrophic releasing hormone from the hypothalamus is going to stimulate FSH and LH. FSH is going to stimulate follicular development and follicular release of estrogen, which will later secrete inhibin to inhibit FSH secretions. Luteinizing hormone is released once estrogen increases during follicular development. It stimulates completion of follicular maturation and leads to ovulation. Table 28.2 summarizes all the homologous structures of the female and male reproductive system. So you can see all the female structures: the ovaries, the ovum, the labias, the vestibule, the bulb, the clitoris, the periurethral glands, and greater vestibular glands, and their homologous structures in the male: testes, sperm cells, scrotum, spongy urethra, intermediate urethra, bulb, corpus spongiosum, glands, prostate, bulbourethral gland. Now, to continue with the female reproductive system, we have to talk about the mammary glands. They are located in each of the two breasts and are modified sudoriferous glands that function to produce milk. Each mammary gland contains about 15 to 30 lobes. The lobes have lobules containing milk-secreting glands called alveoli, not to be confused with the alveoli of the lung, but similar structured cells. Each breast has a nipple containing lactiferous ducts where milk emerges. The roughened, bumpy skin around the nipple is the areola. The areola is roughened and bumped to increase surface area so that a baby has some traction to attach during breastfeeding. Let's put it to picture. So the first thing you notice is the amount of fat that is surrounding these mammary glands. Again, it is supportive. It is insulating and warming the milk that is being produced in here. We have our lobule containing the alveoli, so our lobules, right? With our secondary tubule, so all these tubes. So now we can summarize the entire female reproductive cycle. So in non-pregnant females, they experience cyclical changes in the ovaries and uterus lasting approximately 1 month or about 28 days. The cycle involves oogenesis and preparation by the uterus to receive a fertilized ovum. The ovarian cycle includes changes that occur during and after maturation of the oocyte, whereas the uterine cycle involves changes in the endometrium that prepares it for implantation for that developing embryo. We can break the female reproductive cycle into 4 basic phases. The cycle takes roughly 28 days. It can range from anywhere from 24 to 36 days depending on the female. Those 4 phases are the menstrual phase, pre-ovulatory phase, ovulation, and post-ovulatory. So we can overlap everything that we've talked about so far, including the ovarian phase with our ovarian cycle with our uterine menstrual cycle. So we see that right around the same time during our menstrual phase, our primary follicle is starting to grow and differentiate into the secondary follicle. And we can see the hormones that are responsible for eliciting this effect. We also see that follicle secreting a surge of estrogen. that estrogen is helping to select multiple follicles to mature, while at the same time allowing those excess follicles to degenerate and select the biggest and best secondary follicle. We also see that ovulation right here, day 14, 15 is where we see that egg being expulsed from that Graafian follicle. We see the degradation of that corpus luteum, or that follicle, into the corpus luteum, those granulosal cells secreting two hormones, primarily progesterone with some estrogen. This is our communicatory hormones. This is what's talking to the uterus, saying have fertilized that egg, or I have not fertilized that egg. I am pregnant, or I am not pregnant. If pregnancy does not occur, fertilization does not occur, progesterone stops, estrogen stops, and we enter into menstruation back to day 0. Feedback is an important aspect to regulate hormones, especially in this hormonally controlled cycle. High levels of estrogen during the last part of the pre-ovulatory phase have a positive feedback effect on the cell secreting luteinizing hormone and gonadotropic releasing hormone. This brings about ovulation. We can examine the feedback loop to see who is communicating with who and how this process happens. So let's start with gonadotropic releasing hormone signaling the release of follicle stimulating hormone to luteinizing hormone. FSH communicates with our primary follicle and secondary follicle, allowing that follicle to mature into one dominant follicle. This increasing secretion of estrogens is also, and inhibition by those granulosal cells, is occurring right here in that secretory phase. Now, the positive feedback loop to this process is high levels of estrogen, again without progesterone, stimulate the release of gonadotropic releasing hormone, luteinizing hormone, and follicle stimulating hormone. Where and what it negates. So, moderate levels of estrogen. So notice we're specifying high levels to moderate levels. So moderate levels of estrogen inhibit the secretion of gonadotropic releasing hormone and FSH and LH. Also inhibits secretion of FSH and LH here, right? And it does that by ultimately blocking GnRH. Here comes LH. We follow this arrow now. And this arrow going to talk to that follicle to allow for that egg to be expulsed, so ovulation. We continue to see the degradation of that follicle into the corpus luteum, which is based on increased secretions of inhibin by cells of the corpus luteum, which will negatively impact this by inhibiting FSH and LH. We can also see that increased secretions of progesterone and estrogens by the cells of the corpus luteum is primarily occurring in this secretory phase of the uterus, at which point, if the egg is fertilized, progesterone will continually pulse for the entire 40 weeks. If not, it will stop and we enter and negate this system. Now, formation of the corpus albicans. So again, remember we are assuming that no egg was fertilized. That luteum will degrade further into the corpus albicans, the scar tissue. We stop secretion of progesterone and estrogens, and we have this positive feedback loop. So low levels of progesterone and estrogen promote secretion of GnRH, FSH, and LH, which kicks the cycle all over again. Now, what happens when all those eggs that you were born with have ovulated? This is called menopause. The time that ovulation and menstruation cease is our typical definition for menopause. This age can vary, typically around the age of 45 to 55, but the age would vary greatly dependent on whether when that female hit puberty. The earlier the puberty, the earlier the typical onset of menopause. It is accompanied by a decline of circulating estrogen and progesterone and increases in FSH and LH. So pretty much all of our oocytes die. And this happens because we have scar tissue forming with all those corpus albicans. Few oocytes to respond to the FSH and LH, and then they stop being released. Cessation of cycles for 1 year is necessary to define a woman as being postmenopausal. Now, menopause does have some symptoms. The symptoms include hot flashes, irregular heart rate, vaginal dryness, depression, decreased sex drive, and bone density would decrease. Remember, we are lowering the levels of free estrogen in the body. I mean, if we go back to AP1, we signaled that estrogen was an important hormone necessary for bone growth. Now, some women don't have any symptoms, but the majority of them can recognize some or all of these below. Now, how do you treat this? Now, during these years, doctors sometimes prescribe low-dose oral contraceptives, things like orthotricycline, the pill. This will substitute some of that progesterone and estrogen, trying to alleviate these symptoms. Let's look at some diseases of the female reproductive system. The first one we're going to look at is pelvic inflammatory disease. Now, recall that the fallopian tubes are open to the abdominal cavity. That means there's an increased risk for pelvic inflammatory disease secondary to sexually transmitted diseases. This is the major cause of sterility. Sexually transmitted disease pathogens like gonorrhea infect the uterine tube and can cause swelling, scarring that will prevent the passage of that zygote. If you look at the picture to the right, we see a hysterectomy, and you can see how swollen the fallopian tubes and ovary area is, which will physically block that egg from traveling towards the uterus. Now, this can cause another problem called an ectopic pregnancy that we'll look at in a little bit. Now, who is at the highest chances of having PID? Well, females between the age of 15 and 24. The most common cause of pelvic inflammatory disease is having sex without a condom. And typically, most of these cases are due to chlamydia and gonorrhea. Now, let's look at that ectopic pregnancy that we just alluded to and just introduced a few seconds ago. Now, what happens? A fetus will not survive in the uterine tube. It has to move and implant completely in the uterus. Now, why wouldn't this zygote make its way to the uterus? Well, just like we saw in pelvic inflammatory disease, something can be causing a physical blockage. This prevents the egg from moving through the tube into the uterus. Also, scarring or endometriosis can also prevent this from happening. There has been also seen an elevated risk if you use Plan B too many times. This is also known as the morning after pill, can also increase your chance of an ectopic pregnancy. So ectopic pregnancy is pretty common in women with inflammation in the tubes due to previous pelvic inflammatory disease from subsequent or secondary sexually transmitted disease infections. Another disease we could look at is PCOS, polycystic ovarian syndrome. This is very common in young women where numerous small cysts develop in and around the ovary. What can contribute to this? Well, females can be overweight. If they're overweight, they should have a meal plan to try to reduce weight. If you have PCOS, sometimes you might have problems with fertility. You might also see an early diagnosis, which may reduce the risk of type 2 diabetes, heart disease, and stroke. There are some signs and symptoms: infrequent or prolonged menstrual periods, being overweight, elevated testosterone levels, insulin resistance, and darkened areas of the skin. Now, with excess insulin, this can lead to androgen production, which can also increase your chance of having polycystic ovarian syndrome. High levels of estrogen may increase risk for uterine cancer as well. Next is ovarian cancer, one of the most deadliest cancers for females. And the reason why is because it typically goes undiagnosed because the symptoms are things like lower back pain, symptoms that people experience throughout their entire life and don't typically associate with ovarian cancer. It is the most deadly of reproductive cancers. Most cases are for females 55 and older. Symptoms are very vague: bloating, feeling full, pelvic or abdominal pain, abnormal menses, indigestion, constipation, weight gain, and weight loss, right? So all pretty much typical symptoms. Nothing that your doctor will say is definitely ovarian cancer. Now, if you look to the right, you see how big this cyst is, right? How big this tumor is. So this is typically when it is found when it is in its late stages, which makes it one of the most deadliest cancers. Diagnosis: physical exams, you look for ascites. Pelvic exams, feeling for large masses. Blood tests, pelvic CAT scans, MRI, or biopsies. You can have surgery to remove the uterus, a hysterectomy, remove the ovaries, fallopian tubes, the omentum, plus chemotherapy in later stages. Cervical cancer is another disease of the female reproductive system that we have to look at. It is the third most common cancer in women worldwide, primarily squamous carcinomas associated with HPV. We have different stages: dysplasia, CIS, and invasive carcinomas. We have symptoms: vaginal bleeding, long heavy menses, bleeding between periods, or bleeding after intercourse, or even after menopause. We get vaginal discharge, pelvic pain, bone pain, fatigue, or weight loss. How do you diagnose this? So every year when you go to your OBGYN and they do those pap smears, this is what they're testing for. And if they get an abnormal culture, abnormal cell growth, they may do a biopsy where they freeze off a portion of your cervix and then check it again. An MRI may be another method that they use to diagnose. Treatment: ablation. Either they will electrically freeze or burn away those cell layers. Radiation, hysterectomy, or chemotherapy. Last female reproductive disease we're going to talk about is breast cancer. Now, breast cancer can affect men and women. The lifetime risk is 1 in 8 for women and men 101. So men are typically have been thought to have a less incidence, less chance of getting breast cancer, but we're starting to see that more and more men are being diagnosed with breast cancer. Now, there's different types. There may be ductal or lobar in origin. It may be invasive or non-invasive. There are some signs and symptoms. You can have a breast or axillary lump. It could be firm or uneven. It most likely is not mobile and usually painless. It will change in size, shape. Feeling the breast or nipple can also invert. You could also get discharge from the nipple. Now, how do you diagnose this? Typically, self-exams is the first primary source. Physical exams, visual exams, you notice an abnormality in your breast. Mammography is another way. We use biopsies with needle and excisional techniques to help biopsy test those tumors. Treatment: surgery, a lumpectomy, a mastectomy where we remove either just the lump or the entire breast. Chemotherapy followed by radiation. One of the last topics we're going to talk about are birth control methods. Now, birth control methods are designed to limit the number of children produced by preventing conception. Now, the ultimate way of preventing unwanted pregnancy is complete abstinence. It is the only 100% reliable method. There are other methods like surgical sterilization, hormonal methods, and periodic abstinence. Table 28.3 goes through failure rates for several birth control methods. So it examines the method, and then with regard to failure rates, what happens with perfect use to typical use. So we can see things like vasectomies, tubal ligations in females. Perfect use, the failure rate is 0.1 for male, 0.5 for female. Typical use stays about the same. These are surgical sterilizations. You look at hormonal contraceptives, combined pill like Yasmin, like Cizanodol, like Micronar, right? Or orthotricycline, any orthotricycline derivative. Perfect use 0.3, typical use 1.2. Non-oral contraceptives like the patch, like NuvaRing, emergency contraceptive Plan B, hormone injections. We see perfect use can vary from typical use. And for emergency contraceptive, it is a pill swallow format, so the failure rate is about 25% regardless of perfect or typical use. IUDs, typically perfect use, we get a 0.6% failure rate, and then typical use 0.8%. Spermicides, barrier methods, periodic abstinence, you can see those rates as well. Rhythm method versus symptothermal method, so checking for temperature. So perfect use is low, where we see, look at the typical uses, pretty high percentage of failure rate. Same thing with condoms, vaginal pouches, diaphragms, and cervical caps. So surgical sterilization is an intervention to render an individual incapable of reproduction. For males, we use a vasectomy. This removes a portion of the vas deferens. In females, we use tubal ligation. This ties the fallopian tubes closed. And then we have non-incisional sterilization, which employs the insertion of a coil made of a plastic and metal into each uterine tube. Then scar tissue grows and blocks the tubes. Hormonal methods include oral contraceptives that are designed to prevent pregnancy by inhibiting ovulation. There are many types of oral hormonal methods. Some are combined oral contraceptives called COCs. They can contain progestin and estrogens. There may be extended cycle birth control pills that contain progestin and estrogen, and menstruation occurs every 13 weeks. We have mini pills, which contain progestin only. And why all these progestin? Well, progestin thickens cervical mucus, which prevents sperm, or makes it harder for sperm to make their way into that cervical os. There are non-oral methods, which include the contraceptive skin patch, vaginal contraceptive ring, like NuvaRing. We have emergency contraceptive, EC. These are oral method. 2 pills are taken, one within 72 hours of unprotected intercourse and the other taken 12 hours after the first. This is typically Plan B. There are some barrier methods. These employ a physical barrier to block sperm from gaining access to the uterine cavity and tubes. These include male condoms, vaginal pouches, or also known as female condoms, diaphragms, and cervical caps with spermicidal jelly on top. Another method is periodic abstinence, which is employed when the couple has knowledge of the physiological changes that take place during the female cycle, so going back to those ovulation cycles. The first method used was the rhythm method, so a couple abstains from intercourse when ovulation is likely to occur. The symptothermal method may be used to avoid or achieve pregnancy. This uses normally fluctuating physiological markers such as temperature and changes in cervical mucus color and texture. Remember that temperature is only 0.3 degrees Celsius. That temperature change at ovulation is what they're looking for. This is also known as the family planning method. So you can use this method to plan for families by marking your ovulation cycle. So engaging in more intercourse, when you know that 14, 15, that 24 to 48, 12 to 24 hour window for ovulation is occurring. Next, we can look at abortion. Abortion is the premature expulsion of the products of conception from the uterus. There are methods. Mifepristone is RU486, is a hormone used in pregnancies 9 weeks or less. Basically, this blocks progestin, thus blocking the action of progesterone, resulting in menstruation. Vacuum aspiration uses suction to remove the embryo or fetus, placenta, and uterine linings. Another method that we can to complete an abortion. We can continue abortion. We have dilation and evacuation, which are used together to dilate the cervix and employ suction, and a forceps to remove the fetus, placenta, and uterine lining. Late stage abortion employs similar methods to dilation and evacuation, except it uses a saline solution or surgical method to induce abortion. We can review some homeostatic imbalances in men and women. Men, we talked about testicular cancer, prostate cancer and disorders, and erectile dysfunction. In women, we have premenstrual syndrome or PMS, premenstrual dysphoric disorder, which is pretty common. We see more than 3 million cases a year. It is a severe form of premenstrual syndrome that includes physical and behavioral symptoms that usually resolve or end with the onset of menstruation. Endometriosis, breast and ovarian cancer, and or yeast infections. Some sexually transmitted diseases that we can look at or talk about. We have introduced chlamydia, trichomoniasis, gonorrhea, syphilis, genital herpes, and genital warts. Lastly, we focus on homeostasis. So for the male and female reproductive systems, Basically, they produce gametes, oocytes, and sperm that unite to form embryos and fetuses, which contain cells that divide and differentiate to form all of the organ systems of the body.